My name is Jose Francisco, Project Manager at the IAS-USA. I would like to welcome today's speaker, Dr. Kristine Erlandson, who will be going over the clinical relevance of physical function and frailty measures in people with HIV and will provide insight into appropriate tools for different settings. Welcome, Dr. Erlandson.
Thank you. So as Jose mentioned, my name is Kristine Erlandson. I'm an Associate Professor of Medicine and Epidemiology at the University of Colorado in Denver. And I'm going to talk today about physical function and frailty and HIV, what it means, how we can measure it, why we should care, and lastly, what we can do about it. Just as a reminder, this activity today is eligible for CME credits, as well as nursing credits and pharmacy credits. We'd like to thank our generous supporters who are listed here for this supporting webinar today. And we're going to have a few poll questions. The poll questions will pop out as a separate window, and you should choose your response from the poll questions. Please do not include your response in the chat box. After everyone's answered, we will display the poll responses. If you have questions that we can address at the end, you can include those in the chat box. And I'd like to thank everyone who submitted questions during the pre-registration process. I will hopefully answer a lot of those questions during the presentation, and we'll try to answer more at the end if there's some that remain. So we'll start with a simple poll question. If you can answer where you're viewing this webinar from, the Western U.S., Midwest U.S., Southwest U.S., Southeast U.S., Northeast U.S., Canada, Mexico, Central and South America, Europe, Asia, or Australia, Africa, or other. Okay. And can we see those responses? Looks like the majority of today's group are from the Northeast United States, followed by the Western United States. And our next question, please rate your level of experience in the medical management of HIV infection. Novice, or anywhere from a novice to an expert. And it looks like most of our participants are in that number 3, number 4, with a few experts and a few novices. So we'll try to cover all of those bases today. So now we can move on to the presentation. Some learning objectives for today. I'm hoping that after listening to this webinar, you can describe the clinical relevance of physical function and frailty measures, select tools for physical function and frailty in the clinical and research setting, and then start to think about ways to develop interventions to either attenuate or reverse frailty and impairments in physical function. Now we're going to have a couple of pre-test questions. The first one, which option correctly reflects a consideration for choosing the 400-meter walk or the frailty phenotype in either the clinical or research setting? Number 1, the 400-meter walk can be collected retrospectively. Number 2, the frailty phenotype can be less useful because of a high proportion of older adults who are identified as frail. Number 3, the 400-meter walk test can be easily completed in the exam room. Number 4, the frailty phenotype requires no equipment beyond what's available in the HIV clinic. Or number 4, the 400-meter walk can detect more subtle differences in higher functioning individuals. And it looked like the majority responded that either number 4 or number 5, the frailty phenotype requires no equipment, beyond what's in the HIV clinic, or the 400-meter walk test can detect more subtle differences. And we should cover this response throughout the presentation. And the next pretest question, what is the most effective intervention to prevent frailty and improve early physical function impairments in adults aging with HIV? Is it exercise, a comprehensive geriatric assessment, metformin, or testosterone? Great, and it looks like we have the majority responding that exercise is the most effective, several that think comprehensive geriatric assessment, and a few that had testosterone but then changed their mind. So we will also cover this one throughout the presentation. Okay, so as many of you know, aging is associated with some subtle and some not so subtle changes in physical function. Peak performance is often seen in someone's 20s or 30s, as you can see by the gentleman jogging and the woman walking fairly briskly in the upper left-hand corner. And that decline can be slow in some individuals, particularly those that are very active throughout their life, and a much faster decline in others. The loss of muscles and muscle strength can be particularly apparent in some individuals, such as that seen in Governor Schwarzenegger, seen in the bottom figure. When we think about these changes over the lifespan, several questions come to mind. How can we help our patients, as well as ourselves, maintain the highest level of function with aging? Do these differences in function with increasing age change how we might provide care? And then lastly, why is this applicable to adults living with HIV? Well, first, how can we describe or characterize some of these changes that occur? Much of this model stems from the classic disablement model that was first conceptualized in the 1960s and then later formed the World Health Organization Disability Framework. The basis of this model, shown in the figure on the right, there's some sort of pathology that leads to an underlying impairment. That impairment progresses to a functional limitation and ultimately could lead to disability. So using this framework, impairment refers to a change in body function at the level of the organ. This is something that can be diagnosed on physical exam, on imaging, or on laboratory tests. Could include things such as vision impairment or hearing impairment, osteopenia or osteoporosis, or a loss of muscle mass that's seen on a DEXA scan. Limitations refer to the ability to do something because of an underlying impairment. And this could be assessed via performance-based measures or just someone's self-report of how they're doing in their daily function. Some examples that we oftentimes use in the research setting are a 6-minute walk or a 4-meter walk, also used in the clinic setting, or just some self-report. Some of the performance-based measures might be more preferred for a research setting because they are more objective. Disability or participation restriction, as it's called by the World Health Organization framework, refers to how someone is carrying out their expected activities in the real world. And what's important to note is that disability is very much a social phenomenon. It's dependent on what's expected of the individual within their culture, what the individual expects of him or herself, what resources are available to help them function in their community, and then how their physical environment is set up. So for example, an older man who has severe hearing impairment, vision impairment, and severe arthritis that maybe is wheelchair bound could easily be considered disabled. However, if he has vision aids and hearing aids and has wheelchair accessible transportation, he may still be able to work full time and get out of the house on a regular basis. In contrast to the disability framework, frailty is a separate but really closely related concept describing more of the vulnerability of an individual to stressors that I'm going to talk about in the next several slides. So the general concept of frailty is illustrated here. On the top, we see someone that has fairly mild impairments but's not yet frail. Find my arrow here. But's not yet frail. They have some sort of stressor like a hospitalization or an illness, and then they have a slight decline in their function, but kind of bounce back to normal and continue along in their normal level of function. In contrast, someone who's frail has the same stressor with a hospitalization or an illness, has a decline in function, and isn't quite able to get back to that same baseline. Another stressor comes along and they continue to have this kind of zigzag trajectory downward over time. One of the most common descriptions of frailty is that of the frailty phenotype, which was initially described by Linda Fried encompasses this concept of vulnerability that was seen on the prior slide. The initial description included 5 components of slow gait, or slowness, which is often measured via a 4-meter walk, just a short distance across an exam room. Weakness, which is usually measured by a dynamometer, a special grip-held device that measures grip strength. Low levels of physical activity, low levels of fatigue, both of those self-reported, and then weight loss. If someone has none of these criteria, they're considered robust. If they meet 1 to 2 of those criteria, they're considered pre-frail. And if they meet 3 or more of these criteria, they're considered frail. And notably, some of these are quite subjective criteria, and they do have a lot of overlap with depression. Someone who's severely depressed may also be have sort of a slow gait, may have low levels of activity and feel quite fatigued, and may actually lose weight. The frailty phenotype takes about 5 to 10 minutes to assess. It does require that short 4-meter walking course, which can be set up in the hallway. And then it also requires a dynamometer, which is probably not available in most HIV clinics. It also has to be assessed prospectively. So most of these elements aren't necessarily captured in a routine HIV clinic visit and have to be kind of prospectively incorporated into that visit to have this data available later. Importantly, the frailty phenotype isn't actually an index, but it rather attempts to define the components of this very complex cycle. So multiple factors initially contribute to, losing my arrow here, such as senescent muscle changes and disease, underlying comorbidities, contribute to this loss of muscle mass. This loss of muscle mass affects someone's exercise endurance as measured by their VO2 max, their strength and their power, their resting metabolic rate. These over time can then cause a slow walking speed. If someone's not walking as quickly, they tend to have lower levels of activity, and overall they're burning fewer calories. That decrease in energy expenditure then kind of suppresses someone's appetite, and they may end up chronically undernourished, therefore creating this chronic cycle that feeds back upon itself. Within this cycle, you can see some major components that I have circled here of strength and power, which is assessed by the grip strength in the frailty phenotype, and walking speed, which was assessed by the 4-meter walk. These individual components of the cycles are also associated with increased mortality and poor outcomes in the general population. And similarly, other measures that can be substituted for strength and power, such as the time to rise up from a chair 5 or 10 times, or time to rise up a flight of stairs, other measures of exercise endurance that are substituted for the VO2 max, such as a 6-minute walk time or time to walk 400 meters, are also associated with poor outcomes. And these other outcomes may be even more predictive in more robust persons, those that aren't necessarily frail, and therefore may represent some early changes in this cycle. It's also important to note that frailty by the phenotype is related to and often overlaps with comorbidity and disability, but it's not equivalent. Frailty can exist outside of comorbidity, even though most do tend to have some comorbidities, and similarly, disability can also occur without frailty. Probably the other most common way to think of frailty is the deficit accumulation model, or the frailty index. This model considers variables that increase with age but are not ubiquitous with age and are associated with health status. Something like presbyopia, or the need for glasses with increasing age, is somewhat ubiquitous with age. Almost everyone requires glasses as they get older, and it's also not associated with health status, so that would be an example of a variable that would not be particularly useful for the frailty index. The general concept of the frailty index is that the more things that someone has wrong with them, the more likely it is that they're frail. So instead of scoring this from 0 to 5, the index scores continuously between 0 and 1 and uses the number of variables that are impaired divided by the total number of variables that are assessed. One of the major benefits of the frailty index is that it can be developed for specific populations depending on what's collected in that medical record system or that research database, and it can be done retrospectively by a chart review. The initial frailty index was developed using 70 different variables that are shown here. And these range from activities of daily living and physical function measures, measures of mood, cognition, and neurologic function, such as tremors, more neurologic function, cardiovascular measures, endocrine assessments, and respiratory assessments. And you may notice that a lot of these variables in the initial frailty index are focused on neurologic function. So it does tend to be much more influenced by some of these impairments in memory, impairments in mood, impairments in general mental functioning. There are a few physical function measurements that are included, and these would just be based on what someone could derive from the chart review unless they were collected standardly in that clinic. Some of you might also be familiar with the Veterans Aging Cohort Study Index. This was developed by Amy Justice and colleagues within the Veterans Aging Cohort Study. And it's a similar concept to the Frailty Index, though it uses a minimal amount of readily available labs to predict mortality and morbidity in veterans both with and without HIV. It has been applied successfully to many populations both within and without the VA, within and outside of the VA, both nationally and internationally. And one common thing that we say with frailty is that you know it when you see it, and this simplified version of frailty was developed by Ken Rockwood and colleagues at the Frailty Index, essentially to capture that concept. It's a visual diagnosis of frailty that's based on perception and some guidance to give a scale between 0 and 9. So someone who's very fit, robust, active, commonly exercises regularly would be considered a 1 and have very minimal score on the clinical frailty scale. Someone who has some slowing and some need in things like finance assistance and housework and medications would have a 5. And then someone who's more terminally ill, who has a very low life expectancy, would be considered the most frail and have a score of 9. This clinical index has actually been used in quite a few clinic settings and does seem to perform quite well in predicting frailty and is very quick to assess. So one question comes up is, why should we think about frailty, and why has there been this big interest in frailty in populations with HIV? Is someone with HIV actually at risk for frailty more so than the general population? And this schematic that was published in 2006 by Linda Freed of the Freed Frailty Phenotype and Jeremy Walston illustrates some of the factors that are thought to develop or contribute to the development of frailty in the general population. As you can see, many of these are the same factors that we think underlie this kind of accelerated or accentuated aging process that we see in people with HIV. There are underlying disease triggers such as molecular factors like oxidative stress and telomere shortening. There's an underlying high level of inflammation and some neuroendocrine dysregulation. We see high levels of these inflammatory markers and evidence of metabolic derangement such as low insulin-like growth factor. We see impairments in glucose metabolism, low levels of cognition, and some of these body composition changes of HIV. And our group, as well as many others, have shown that many of these factors, including inflammation, glucose, body composition markers, are strongly associated with frailty or with some of these earlier steps of frailty like gait speed in people with HIV. In fact, a very similar schematic that was first presented by Steve Deeks at IAS many years ago and later published in The Lancet kind of encompasses the same framework that we think may underlie a lot of the comorbidities in HIV and then ultimately likely lead to frailty. We see impact on the immune system, high levels of inflammation, possibly triggered by microbial translocation, the role of lipodystrophy and antiretroviral toxicity on some of those underlying genetic components and that body composition factors, and then certainly the additional role that HIV might play. And so with these pathways from both HIV and aging, is frailty more common or earlier in people with HIV? And certainly a few studies both in people with HIV and having a comparable uninfected control group with some of the risk factors suggest that yes, frailty does appear to occur more commonly in people with HIV. The figure on the left here shows data from the Amsterdam HIV cohort, and you can see that frailty is more common in people with HIV across nearly every age range after accounting for some of those factors that differed between the controls and the people with HIV. Take, for example, people age 65 and older. You can see that those with HIV have about 20% frailty compared to only about 5% frailty in their HIV uninfected group. The figure on the right shows data from the multi-center AIDS cohort study of men with HIV and men at risk for HIV infection. And you can see similarly an increasing prevalence of frailty that really starts to separate at about age 50 and older, with those with HIV having a much higher prevalence of frailty shown by the filled-in diamond compared to the men without HIV in the empty square. The prevalence of frailty in other populations of HIV really varies quite widely depending on the age of the cohort that's included, the definition or kind of the cut points for frailty that are used, whether they're using the exact same cut points as the initial frailty study or basing cut points off of an HIV uninfected control group, and then also the proportion that are on antiretroviral therapy. You can see in this first study on the slide in Indonesia, the group is pretty young, starting at about age 30. All of them are on antiretroviral therapy, and the prevalence of frailty is only about 4%. Across more of the middle-aged cohorts, as you can see through several of these middle studies, we see probably about a 6 to 8%, up to 10% rate of frailty. Other populations with intravenous drug use, such as the ALIVE cohort, see a little bit higher rates of frailty, up to 15%. And then in populations where the focus is on individuals with a low CD4 count or that have a lower proportion on antiretroviral therapy, that proportion of frailty increases pretty dramatically. And as I mentioned earlier, some of these physical function impairments within the cycle of frailty, such as that measure of strength and power, as well as slowness or gait speed, may help to identify those with some early impairments that have not yet become frail. And this also appears to be true for people with HIV. Here we looked at frailty and then either a single or combined physical function impairments by a short physical performance battery. The SPPB, or short physical performance battery, is an objective assessment that includes the same 4-meter walk that's included in the frailty phenotype, time to rise from a chair as that measure of strength or power instead of grip strength, and then a measure of balance where someone stands heel to toe for up to 10 seconds. And this data is from the baseline assessment of about 250 participants in the REPRIEVE study, which is a population of individuals with HIV aged 40 to 75 who had low to moderate risk of cardiovascular disease and were randomized to either receive a statin or a placebo. So this is from baseline prior to receipt of drugs. And not surprisingly, the prevalence of frailty in this group of middle-aged individuals with low cardiovascular risk was pretty low, so only about 6%. We actually saw that about 50% of participants, however, had some level of impairment on the short physical performance battery, indicated by a score of less than 12. So they had some sort of impairment on the short physical performance battery. As you can see in the small red bar here, although we did see an increasing proportion of frailty as people had lower and lower scores on the short physical performance battery, that the group that actually were frail, that we would have picked up on this test, that we could potentially look at intervening upon or kind of focusing our efforts on, was actually quite small, just a small group of individuals that have frailty, but many more that had physical function impairment. Importantly, we separated out one of those components, specifically the inability or the difficulty in rising from the chair 5 times. So this included just a slow ability to rise from the chair 5 times, not just an inability. We looked at anyone that had less than a perfect score on this, so they had a certain time cutoff, and we saw that more than 50% of individuals had some impairment on their time to rise from the chair 5 times, suggesting that perhaps this one simple measure may be a really good test to quickly identify even young, fairly healthy individuals that have some sort of decrease or impairment in their muscle strength and power. Other studies have explored these single measures of gait speed, that measure of slowness, and then also that measure of strength, measured by the grip strength here in the multi-center AIDS cohort study. And we see that both gait speed and grip strength are associated with a decline in aging, particularly in those with HIV. In the figure on the left, you can see the men with HIV in the red line and the uninfected controls in the blue line. And there seems to be a clear, faster decline in men with HIV starting at about age 50. We see a similar decline in those with HIV starting at about age 60 in terms of grip strength. And I don't want to spend too much time focusing on the clinical and demographic factors that contribute to frailty, as this has been extensively reviewed in really nice review articles recently. But I did want to mention one study that we did in the AIDS clinical trials group HALO cohort. This cohort includes about 1,000 people with HIV aged 45 or older. They were all initially randomized to their antiretroviral therapy through an ACTG, or AIDS clinical trials group clinical study. Some of them had changed off of that initial therapy, but about 90% of them remained, had an undetectable viral load and continued on antiretroviral therapy. Many of the factors that contributed to frailty in our cohort have also been seen in other cohorts, including many socioeconomic factors such as education and insurance, Not surprisingly, we saw that increasing age was associated with frailty. We also saw a link with some modifiable risk factors, things like obesity, lower levels of physical activity, and smoking. Additionally, we saw some signal that antiretroviral therapy may play a role. In fact, we saw that initial randomization in an ACTG study to an NNRTI, which was almost entirely efavirenz in this cohort, was associated with frailty at a later stage, even if someone had transitioned off of that therapy. And we also saw that neurocognitive impairment was associated with frailty. And there's been a nice link between neurocognition and frailty, and kind of a neurocognitive frailty that's been published quite a bit in the general population. And importantly, this also shows that frailty in this cohort was not entirely comorbidity driven. The only comorbidity that really came out as a significant predictor for frailty was this neurocognitive outcome. So what are some of the reasons that frailty is so important in people with HIV? Well, we certainly see that frailty or some of these physical function impairments can predict poor outcomes such as falls. This is data that we've looked at in 3 different cohorts, where we see that the risk of recurrent falls in people with HIV ranges anywhere from about 25 or 30% to up to 40%. In a cohort in Colorado, we looked between age 45 and 65, all on antiretroviral therapy. We looked at how some of these physical function assessments might be associated with fall risk. As you can see, difficulty with tandem stand, which was that balance test from the short physical performance battery, was strongly associated with someone having a risk for fall in the subsequent year, as was the 2 measures of exhaustion or fatigue and weight loss or shrinking from the frailty index or frailty phenotype. In the multi-center AIDS cohort study, we looked at the risk for falls in an older population, those 60 and older, and here we saw that the time to rise from a chair 10 times was strongly associated with falls, being a recurrent faller, as with someone's sensation or their confidence in their ability to balance, the ABC test. We, interestingly, in this cohort, didn't see a strong association with the overall components of frailty, either being pre-frail or having frailty. The Women's Interagency HIV study also looked at the risk for frailty and some components of frailty with falls, and found similarly that frailty and those same components of being fatigued and having weight loss or exhaustion and shrinking were also significantly associated with the risk for a fall. The frailty is also strongly associated with the risk for survival, and we tend to see a bit of a synergistic effect, the combination of both HIV and frailty decreasing the risk of, or the chance of survival. This is data from the ALIVE cohort of injection drug users with and without HIV infection. And in the top line, you see the survival curve for someone without HIV and without frailty. And this is at about 95%, 97% over 4 years. In contrast, if someone has either HIV or frailty, their risk of survival decreases to just below 90%, or their chance of survival. And then combination of both HIV and frailty, that chance for survival decreases to about 70% over 3 to 4 years. We see a similar effect in a different cohort of the age HIV cohort, which is the ALIVE cohort tends to be a bit different since it does include injection, or it's entirely injection drug users. This is probably a little bit more similar to cohorts like the multi-center AIDS cohort or the Women's Interagency HIV study. This is a large study looking at over 1,000 participants, 38 of whom died over the course of the follow-up of the study. And they similarly found that frailty was associated with mortality among their participants, both with and without HIV. In contrast to the ALIVE data, they did not see that HIV interaction and found that frailty had a similar effect on mortality regardless of HIV serostatus. Kind of going back to those individual components and some of those higher level physical function markers, the ALIVE cohort also looked at survival by the short physical performance battery. If someone had a high score greater than 10, their survival was much higher than if someone had a lower score, indicating more impairment on the short physical performance battery. And they similarly saw that synergistic effect where someone without HIV and with a normal short physical performance battery had the highest level of survival in combination, or either the short physical performance battery or HIV had a similar effect on survival, and then in combination, both HIV and lower performance on the short physical performance battery was associated with a much higher risk of death. And we were interested in how these tests performed over time. Is there one test that seemed to be better at predicting mortality? Are they all fairly similar? And so in this study, we looked at about 360 people aged 45 to 65, who were enrolled in a cohort in Colorado about 8 years ago. We followed those individuals just via chart review over the course of 8 years. 35 of our initial cohort died, 75 were lost to follow-up, mostly moving from the area. We compared all of the measures of physical function that we looked at: frailty, the short physical performance battery, just the chair rise, an individual test, and some of the individual components of frailty like grip strength and a short walk. And we also looked at a longer walk, a 400-meter walk, so 10 times the length of that short walk included in the frailty index. We found that all of our measures, except for grip strength, were associated with an increased risk of death over time. And then we found, when we compared them, that the Veterans Aging Cohort Study Index, that kind of measure of the frailty index or accumulation of deficits, and the 400-meter walk, the longer walk that kind of pushes a little bit more at that endurance level, had the best prediction of mortality over that 8-year time period. Frailty also seems to have an effect on the development of other diseases. This is data from the HALO cohort, again, of individuals that were in the AIDS clinical trials group, about 1,000 participants. And we compared the impact of frailty on the development of cardiovascular disease or the development of diabetes over time. As you can see in the large circle, we saw that frailty was associated with both the development of cardiovascular disease and the development of diabetes over the course of a couple of years. We also just looked at grip strength and just looked at gait speed as simple measures of physical function and found that grip strength was not associated with cardiovascular disease or diabetes, but we did see at least a trend towards slow gait speed and cardiovascular disease or diabetes over time. We also found that in people who changed their frailty status, so if they increased their frailty score over the first couple of years of the study, they had a 4-fold increase in their risk of mortality. So certainly supporting the clinical relevance of frailty and these measures of physical function and outcomes. So with this in mind, you're kind of thinking, what tools should I choose? Should I look at physical function? Should I look at frailty? Should I look at disability? And I think the biggest question here comes back to, what's your question? And what are you trying to answer? Where are you trying to intervene? And what is the purpose of introducing these measures in a study or in clinic? And so just to recap, physical function, which could be looking at gait speed, grip strength, or chair rise time, is going to find an individual who's at high risk for subsequent disability and frailty. These individuals probably have the greatest potential to reverse impairments with prevention and intervention for kind of identifying those early impairments. They also have a great chance for reversing some impairments with rehabilitation, such as physical therapy or occupational therapy. And at this stage, exercise, if someone is obese, decreasing weight in a safe and healthy manner can also help improve physical function, as we see strong associations between obesity and gait speed impairment. And then emphasizing healthy nutrition. In contrast, frailty is really identifying that individual who's vulnerable to stressors. And so when we're trying to intervene on frailty, we are most trying to minimize the risk for progression, avoiding unnecessary stressors, and avoiding hospitalizations, maximizing care of comorbidities, talking about the risk and benefit of certain procedures that maybe aren't necessarily going to benefit over time. Treating those, again, coming back to exercise and nutrition, are probably just as important for frailty as well. And then, as I mentioned earlier, disability really implies that there's more of a decreased access to healthcare and resource support. And so when we're trying to intervene upon disability, it's more of connecting an individual to the community resources they need. Do they have the right level of social support? Do they need home health assistance? Should we be talking about moving that individual to a skilled nursing facility? And then also, I think social isolation, I really focused on it in disability, but I think that component comes across in a lot of these, particularly in the times of COVID. And so when we look at the individual tools and kind of think about which tool you might choose to answer some of these questions, I touched on some of the pros and cons of many of these tools already, but the frailty phenotype, very well validated. We see lots of data in the geriatric literature as well as in the HIV literature. It does require a dynamometer, which I don't think most HIV clinics tend to carry. I think some geriatric clinics do. There is some thought that maybe we can substitute that grip strength measure with a different measure of strength, such as chair rise, but we don't necessarily have that assessment validated. As I mentioned earlier, it does have a lot of overlap with both cognition as well as depression and HIV. And we do see a lot of a kind of a floor effect. There's a lot of individuals that are either pre-frail or non-frail, and it doesn't give us quite as much room to intervene and try to prevent. It can also only be assessed prospectively. The Frailty Index or the VACS Index is easy to derive from labs, and we can collect it retrospectively. It doesn't necessarily include a measure of physical function, and depending on how this is measured, it may be a little bit more difficult to intervene. If one of the criteria is cardiovascular disease, it may be difficult to remove that component, even though that cardiovascular disease may be maximized in terms of prevention and treatment. The short physical performance battery is very well validated in the geriatric literature, and there's a growing literature for its use in the HIV population. It has objective outcomes only, and it does only require a chair and a 4-meter walking space, which could easily be done in the clinic. It does take about 5 to 10 minutes, and similarly has to be done prospectively. And as you saw from the data from the REPRIEVE study, it does have a fairly high ceiling effect, where a lot of individuals will be identified as having perfect function, even if they may have some slowness and some other mild impairments. The chair rise time can be used as the 5 chair rise time that we use in the short physical performance battery, or there's a range of variations of this where we have people rise for 10 times and measure their outcome as a continuous measure of time, or how many chair rises can be completed in 30 seconds, and all of those have been used and published upon in the literature. With this continuous scale tends to give it less of a ceiling effect so that we can really detect a range of values over a larger population and kind of identify those with really high function, not just those with high function or low function. Because of the ability to rise from the chair, this probably is a bit more impacted by people that have severe knee arthritis, so that might be a limitation, and it similarly has to be done prospectively. Grip strength is associated with increased mortality, a lot of data in the literature. It does require a dynamometer, which has to be regularly sent off for calibration to make sure it's accurate. And it's also impacted by arthritis in the hand, which a lot of older individuals tend to have pretty severe thumb arthritis and may have some difficulty squeezing it. The 400-meter walk or the 6-minute walk time are both used to identify a little bit more of exercise endurance, kind of a higher level of function. A quarter-mile test is going to push people more than just a short distance across the clinic room. It also provides a continuous outcome and can identify some more subtle impairments. It does take quite a bit of time, and you need to have a space to do it, not necessarily 400 meters. We use a 25-meter walking course, and then participants finish several laps of it in our clinic. And then questionnaires can certainly be easy to standardize. They can be done in a waiting room or by mail or by telephone. And they might be more appropriate as kind of a brief screen to identify individuals with impairments. But they're subjective, and subjective assessments are surprisingly hard to try to intervene upon in clinical studies. So with that in mind, the next question that comes up is this test that I'm thinking about intervening and using in the clinic or in a research study actually feasible? And we don't have a lot of data on this in the HIV clinic. How do we implement this in the HIV clinic setting? But Heidi Crane published an article on this last year in Open Forum Infectious Disease, looking at the feasibility of administering the short physical performance battery across 3 HIV clinics. In their study, they had 2 clinics that were able to administer the test either before or after a routine clinical visit, and one of the clinic sites actually required participants to return for a separate visit. The time to actually do the assessment was only about 7 minutes. You can imagine that was a little bit of a pain for participants to have to return for a 7-minute test another day. The time to train staff was only about an hour. And the study concluded that it was feasible to implement this test without serious disruptions or injuries. But I would argue for those people that had to return for a 3rd visit, that was a bit of a serious disruption in their schedule and that they weren't able to complete it all within 1 visit. So if we decide we're going to do some of these measures, how might we actually implement this in the HIV clinic? So here's an example question, or example case. We have a 68-year-old woman who has generally fair health. She has treated HIV. She's obese, has a BMI of 32, but really no other pertinent medical problems. She's a non-smoker. She doesn't have diabetes. However, in further questioning, she admits that she has some difficulty walking several blocks. She has some difficulty with her balance, and she really has some problems kind of managing her money, which she attributes to a thinking problem. She's due for her mammogram and a colonoscopy. So which of the following would you recommend? You refer her for a mammogram and a colonoscopy. You tell her that the risk is probably greater than the benefit of her mammogram or colonoscopy, or you tell her that the risk is probably greater than the benefit for both, but it's her choice, and really her thoughts and feelings should inform the decision. So go ahead and use your poll function to answer that question. Okay, it looks like the majority have chosen number 1, which is refer for mammogram and colonoscopy. Good? Okay. And so if we think about how the impact of her physical function may inform our decision as to something like cancer screening, there's a tool called ePrognosis. It's not specific for HIV, it's just for the general population, but you can use this calculator. You plug in several factors such as her age or gender, her smoking, whether she has certain comorbidities, and then it tells you whether the risk or the harm is greater for certain cancer screenings or other assessments. So if I plug in all of her information into this calculator, but I don't comment on her impairments in physical function or in cognitive function, I have a clear answer that there's a definite benefit. Screening for breast or colon cancer is much more likely to help this person than to harm her, and screening would be recommended. So if I go back and I use all of that same information for this patient, but I plug in her impairments in cognitive and physical function, there's a clear shift in whether she has a benefit. It's not clear that getting this patient screened for breast or colorectal cancer is actually going to help her. And I think it really highlights that someone's survival or someone's benefit from some of these procedures, coming back to that vulnerability to external stressors that we see in frailty, and that she may actually have harm from some of these. Now, obviously, one of the things that we talk about in geriatric medicine is what matters most to the patient. And so this should be really a discussion of, do you want this testing? If something came back, would you want to go through with this? But I think letting her know that maybe her benefit isn't quite as clear as we initially thought just by kind of looking at her and her comorbidity risk, and that there is an added benefit in checking some of these and considering some of these functional impairments in making clinical decisions. And so I think we could also use some of these frailty assessments or some of these physical function measures to help think about, do we continue cancer screening? Do we add aspirin or take away aspirin in patients that maybe have a higher fall risk and might have more harm from falling and being on high-dose aspirin? Is there still a benefit of statin after a certain age in some of our patients that are frail or have higher levels of impairment? And also thinking about advanced care planning. Perhaps someone who's 59 who really didn't have a lot of medical problems is actually higher risk and has a lower prognosis, higher risk for mortality over the next 5 to 10 years than we think, and we need to sit down and kind of talk about advanced care planning with that individual. As we move into kind of long-term primary care for many of our older adults, we also ask the question of how often do we need to be seeing older adults in clinic? And some of these assessments of physical function may help inform the frequency of clinic visits. Perhaps an individual who's frail should be seen every 3 months, whereas those that are not frail could be seen every 6 to 12 months. Some clinics are also setting up assessments or referrals for geriatric care, and these patients with impairments might be a perfect initial referral for a geriatrician or for geriatric assessment, or identifying those that are at need for home services to help prevent some of that disability over time. Other specialties are also incorporating some of these measures of frailty, and I think can help kind of think about the way and frame the way that we incorporate these in the HIV clinic. In the cancer realm, frail and pre-frail cancer patients tend to have the highest risk for morbidity, mortality, postoperative complications, side effects and complications with chemotherapy. And so some cancer centers are using frailty to help inform chemo decisions or surgical decisions should someone undergo a massive debulking, or is their risk greater than their benefit after undergoing a major surgery. Frailty has also been used in a cardiac setting to help inform the type of surgery for valve replacement, whether someone should have an open surgical aortic valve replacement versus a transcatheter aortic valve implantation, kind of a more minor procedure versus a more major procedure, depending on how long they think or how well the patient might tolerate surgery. A lot of data on frailty in the transplant patient population, particularly in patients with kidney transplants who may have a live donor, and is that patient at such high risk of undergoing a major surgery like transplantation, or what are their outcomes expected after transplantation? And then lastly, frailty can inform a lot of decisions, or a lot of outcomes in the ICU, such as length of stay, post-ICU disability, nursing home admission requiring or following a hospitalization, and may help some patients think about, if I should get sick at home, what are my advanced care planning directives, and do I want to go to the hospital? What are my chances of actually getting out of the hospital and having a same level of function should I end up in if I'm frail? This has also been applied well beyond HIV. This is the COVID-19 decision support tool that's used by the National Health System in England. And you can see that number one that informs the COVID decision support tool is someone's age. And then that same clinical frail scale that I showed at the beginning, that kind of gestalt feel of is someone frail or not, they get a point, or they get the number of points that they are in the frailty scale, and then they also have the addition of comorbidities. Depending on if someone has a lot of that, has frailty or has comorbidities or a high age, and they're less likely to survive from COVID, they may actually not have them go to the unit or get intubated or some of the more aggressive cares, just thinking that their outcome is going to be quite poor. There's been some studies using the same clinical frail scale on survival in older adults with COVID in Europe. I think some of these frailty measures might also be important endpoints to consider in the design of clinical trials that aren't necessarily related to frailty. There's really been a shift at the Federal Drug Administration to use patient-centered, clinically meaningful outcomes, which I argue some of these physical function and frailty outcomes clearly are. These outcomes ask the question of how do patients feel, function, or survive. And so in addition to virologic endpoints that we might use in antiretroviral treatment therapies or anti-inflammatories or other adjuvant therapy for HIV, do these newer regimens actually impact the subjective and objective physical function of older adults with HIV? We're looking at a little bit of this in that REPRIEVE study that I mentioned earlier. We have a sub-study of REPRIEVE where we're looking at the impact of statins on subjective and objective physical function over time to see if giving statins to middle-aged people that have relatively low or moderate cardiovascular risk actually can have a beneficial effect on physical function through a decrease in inflammation. While we wait for data from REPRIEVE, we looked at this same question in the multi-center AIDS cohort study where we compared the impact of consistent statin use in men with HIV or men without HIV, never use of a statin or intermittent use of a statin. We saw a very similar change in physical function and gait speed here over time in those that either didn't use a statin or consistently used a statin after we adjusted for the risk factors that would inform statin use, such as their cardiovascular risk score. And in contrast, those that were only intermittently on a statin actually had a greater decline in gait speed over time. We also see this strong association between cytomegalovirus, or CMV, and frailty, and this has been demonstrated in the general population, general geriatric population, where those that have either CMV-specific cells that are kind of targeted in the immune system towards fighting CMV or higher CMV immunoglobulin have a higher rate of frailty. This has also been shown in HIV. But whether we can actually target CMV to decrease frailty or prevent frailty is not known. Most of our older CMV therapies were quite toxic as well as quite expensive, and so weren't really tested in clinical trials to see if they had a lot of benefit on physical function. However, the more recent introduction of letermovir, which is a safer agent with anti-CMV activity, offers a potential therapeutic option. And this drug is being studied in a ACTG study to look at the anti-inflammatory and cardiovascular effects on people with HIV, and we were able to incorporate some secondary endpoints of frailty and physical function in this cohort. So see if we can actually improve these other secondary outcomes of physical function. And so when we look and think about where we might intervene, we think we, find my arrow here, so we know that with normal aging, someone might have a slow decline in their physical function performance over time, as we expect with normal aging. And then maybe in the last few years of life, someone may dip into this frailty phase where they really have that high vulnerability and a risk for disability. In contrast, someone who has a more accelerated aging process, such as we might see with some chronic diseases, potentially in some individuals with HIV, there's a much more rapid decline in physical function early in life. Someone spends a good majority of their middle life in frailty and then actually lives with disability and some of the consequences over a much longer period of time. And so if we're targeting this individual who's way down here in the disability curve or even into this frailty stage earlier in life, it's much harder to move them back to that normal aging trajectory. We have a long way to go in terms of physical function and kind of bringing them back to that normal trajectory. However, if we can intervene at a much earlier stage and identify those that have just more subtle impairments in physical function, then we can hopefully return this trajectory to the normal aging trajectory and keep people's function much higher for a longer period of time. When we look at the geriatric literature on how do we intervene with frailty or how do we intervene with some of these physical function impairments, you can see that clearly the answer, regardless of where someone is in the frailty scale, is almost always exercise, 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 exercise. And although it would be great to have a magic pill to prevent and reverse frailty, as this doctor tells his patient, to treat your high blood pressure, your diabetes, your hyperlipidemia, your osteoporosis, take this new pill every day. Take it out for a jog, and then take it to the gym, and then take it for the bike ride. And really, I think exercise is one of the most important activities and interventions that we can do to consistently improve physical function and reverse frailty over time. Most of our data of the impact of physical activity or exercise on outcomes actually focused on lipodystrophy or improving CD4 count or decreasing wasting in the early AIDS days. Some of the more recent studies have focused on physical function outcomes as an important marker. And then there are a few studies shown here with the asterisks in the first three actually focused on interventions in older individuals. So we can see that high exercise or moderate intensity exercise improves a 400-meter walk. Resistance exercise improves muscle strength. Brisk walking improves a 6-minute walk time. And then in some younger cohorts, aerobic and resistance exercise also improves 6-minute walk time, or that measure of exercise endurance, VO2 maximum. So our question was, we know that exercise can improve physical function, but in individuals who have a lot of underlying inflammation and they have muscle aches and pains at baseline neuropathy, how much exercise response is enough? Is a higher intensity exercise potentially too much that people may have more pain and aches and not have as much benefit? And does that response differ in people that have HIV or don't have HIV? And so to answer this question, we enrolled 69 sedentary people with HIV and uninfected controls between age 50 to 75 who had no contraindications to exercise. We had them exercise at our research gym, supervised, 3 days a week. They started on the treadmill for about 15 minutes at a time, and then over the course of 24 weeks, we increased that to 50 minutes to meet the requirement for the CDC physical activity guidelines each week. We also added 3 different standard strength measures, so a leg press, bench press, a lateral pull down, and then rotated at different exercises to kind of use all muscle groups and keep people from getting as bored. All of our participants started at 12 weeks of a moderate intensity exercise, and then halfway through, we randomized half the group to push their exercise intensity up to what we call the high intensity exercise based on their baseline measurements of VO2 max and their strength via a 1 repetition maximum. Or we had the group continue with that same moderate intensity exercise for a different 12 weeks. So this shows the summary of our results, and I'll go through it in detail because it's kind of a busy figure. But on the bottom axis here, you can see the percent improvement between 0 to 12 weeks in this darker colored bar, and then in the second 12 weeks in this lighter colored bar. The people with HIV are shown in the red bar and our uninfected controls in the black bar. And then you can see the different measures of physical function that we assessed on the y-axis with chair stand, time to stand from the chair 10 times, 400-meter walk, and a lot of those measures that we've talked about. So first, we saw that our participants had really impressive improvements in their physical function with the 24 weeks of this study. VO2 max can be somewhat difficult to improve, and we saw almost 10 to 20% improvements in VO2 max. In some of our strength measures, we saw 45% improvements over the course of the study. The chair rise time, we saw 30% improvements. And most of those improvements actually looked pretty similar between the people with HIV and our uninfected controls. When we compared the two, we saw that our people with HIV actually had significantly greater improvements in their 400-meter walk time, that important endurance measure, the time to climb a flight of stairs, and their VO2 max, a measure of exercise endurance again. So really impressive improvement. Our other question was, does the dose of exercise matter? And so here we looked at the effect of high intensity versus moderate intensity. The people with HIV are shown in the pink and the red bar, and then the high and moderate intensity in the control group in the green and the blue bar. Overall, we saw that the people randomized to high intensity exercise had significantly greater improvements in their measures of strength, as shown by the p-values listed on the right. And generally, the improvements actually were pretty similar between high and moderate controls. We were also interested in improvement in frailty. Interestingly, none of our participants that enrolled either in the HIV group or the uninfected controls actually met criteria for frailty. Not unexpected, since most of our frailty prevalence seems to be at about 6%. We did have many that met pre-frail criteria, and you can see that breakdown in the group on the left, which are our people with HIV, far more than 50% of individuals started with some pre-frailty at baseline, and that decreased with the marked increase in those that were considered robust or had no criteria by 24 weeks. Interestingly, in the controls, we really didn't see that much of a difference in the frailty measures. And then lastly, we looked at measures of lean mass, so kind of an estimate for muscle mass, and saw improvements in both people with HIV and controls. Only the group with HIV actually reached statistical significance. And then we saw significant decreases in fat mass in both individuals. However, despite these marked improvements in function, about 3 months after our study ended, we called our participants back, and about half of them were exercising just 1 day a week. A few were exercising a few more days than 1 week, more than 1 day a week. And so I think this was a little bit discouraging after our participants saw these major improvements that so many stopped exercising. And so our big question after the end of the study was, how can we keep people active throughout their lifespan to really prevent frailty and keep these declines from occurring over time? And so one option might be center-based exercise is hard. Can we have people do these exercises at home? And we do see some data from home-based exercise interventions in people with HIV, where physical activity counseling did help in addition to an exercise prescription. They saw improvements in chair rise and 6-minute walk distance. The percent improvements weren't as large as ours, but they were certainly some improvements. A home-based rehabilitation program in KwaZulu-Natal looked at training community health workers to help participants with walking and strength and functional training at home, and also saw significant improvements in their 6-minute walk distance. And then a home-based walking program in South Africa similarly saw some improvement in 6-minute walk distance. So some of these home-based exercises probably can have some benefit. Some people don't like to walk or get really bored walking and want to mix things up with some different exercises. And a recent study published by Allison Moore compared Tai Chi with cognitive behavioral therapy, as well as text messaging in older adults that had HIV and chronic pain, and saw significant improvements in the intervention group that received the Tai Chi, the behavioral therapy, and text messaging of 2 points, more than 2 points, which is quite impressive for the short physical performance battery. Another study looked at yoga and found improvements in blood pressure, less stress, and substance abuse, so other kind of quality of life measures, not specifically physical function. And then some physiotherapy interventions looking at goal setting, stretching, and exercise and endurance have also had marked improvements in physical function. So although we found that higher intensity exercise had the most improvements, really any exercise is better than no exercise. And as providers, we can just encourage that participants start with small, simple steps. The goal is to kind of change these behaviors every day over time to have consistent, long-lasting behaviors, not just to get people to exercise for a month or two and have some initial improvements. Ideally, per recommendations from the National Institute of Aging, our exercise in older adults can kind of target these 4 areas, which may add some more variety and keep people more interested. These can be simple things people can do at home, such as walking, yard work, or just climbing up a flight of stairs in their home several times. Adding weights can be really important for those improvements in muscle strength and power, which we saw have a fit into the frailty cycle. And these can be simple things as well, such as lifting a gallon of milk or a bag of flour or other things that people have at home. Balance exercise is also very important in terms of preventing falls and helping to keep people more comfortable with walking outside. And these can be simple things such as finding a Tai Chi video online or doing just a heel-to-toe walk, kind of walking in a line at home to try to work on balance on a carpeted surface where there's minimal risk for falling, or even just practice standing on one foot with a chair nearby to balance if someone should feel off center. I think in the times of COVID, many people have looked for some exercise videos online, and there's some great videos from Silver Sneakers as well as the Go for Life program through the National Institute of Aging that have older adult workouts for yoga, for other cardiovascular exercises, Tai Chi, strength training. So lots of simple things that people can do at home that are free that can get them exercising. And as you may have seen in one of the studies, one thing that has been beneficial for some populations in some studies is an exercise prescription. We published this last year in AIDS and have this printout prescription as one of the figures. So you can go into the article and print off the PDF as a print off the figure as a PDF and give this to a patient. But this provides some general exercise guidelines. It's specific for people with HIV, kind of talking about how exercise is safe for anyone, including those with HIV. We provide some general exercise recommendations, some tips on how to start exercising, some tips on goal setting, and then actually a prescription so that the provider can write out some specific recommendations to try to increase things gradually. And then trying to set a goal for each week and seeing patients back as often as you can, or just touching base via telephone or telehealth to try to help them increase these goals each week to get to a target goal where they feel comfortable with exercise. So in addition to exercise, are there other interventions that we can offer that may further improve physical function? We don't know this in the HIV population as well, but we do see some studies, including this landmark study that was published in New England Journal in 2011, that compare the impact of a diet intervention in addition to an exercise intervention in older adults with obesity. And this specifically was older adults that had a body mass index greater than 30, so it may not have the same benefit in a thinner population. But in this group, you can see that the group that had the greatest improvement in their physical performance scores were those that had both the diet and exercise intervention, followed by those that had the exercise intervention and then diet and control. So particularly in overweight older adults, there may be some additional benefit to weight loss combined with exercise to help preserve that muscle mass. There's also been an increasing interest in the comprehensive geriatric assessment and some of the geriatric evaluation and management programs or PACE programs in the general geriatric program, and we've seen a little bit more of this incorporated into the HIV setting. When we go back and we think about this concept that frailty is a condition in which multiple body systems lose reserve, the comprehensive geriatric assessment kind of incorporates the overall care rather than system-focused care and tries to meet with each person individually, understand where their gaps in care might be, and connect them to appropriate resources or other consultations to kind of coordinate care as much as possible. And so you can see several clinics both in the US and abroad that have really tried to incorporate some of these concepts of geriatrics into their clinic, including things like the comprehensive geriatric assessment and just gerontology input to kind of try to incorporate a more broad spectrum of care and hopefully prevent some of these frailty declines, or at least identifying those that are frail for appropriate additional services. I think with the changes that we've seen over the spring in terms of the COVID crisis, this also raises the opportunity of virtual visits, and could we have more frequent virtual visits with some of our patients that perhaps are more frail to touch base on some of these issues, or even use some of the virtual visits for geriatric care where there may be a lack of geriatric services in some communities. And then lastly, some patients really can't exercise due to significant disability or other impairments, or they can't exercise to the intensity that's needed to really reverse some of their impairments. And so sometimes we do need to turn to a pharmacologic option to either complement exercise or to replace exercise in some populations. There's been several studies that looked at various treatments, either targeting muscle, targeting fat, targeting inflammation, or kind of this anti-aging effect. And most of them really have not found much of an effect on physical function. Testosterone has shown some benefit, including improving muscle mass, but most of the studies actually haven't shown an improvement in muscle strength, just the effect on mass. We do see potentially some promising data with metformin. Metformin, the diabetes drug, and so the reasoning for that would be that we see a strong correlation between diabetes and impaired physical function and frailty. Metformin is very safe, it's a low cost. In some studies it has been shown to improve lifespan and decrease all-cause mortality, as well as slow cognitive decline and improve grip strength. So certainly a lot of data suggesting that it may have a benefit. Unfortunately, in one study where they randomized individuals to receive metformin with or without exercise, the group that received both metformin and exercise actually had some blunted improvements in some of their muscle function and mitochondrial function that they had with exercise, suggesting that maybe the combination doesn't actually add benefit. I think we'll know a lot more about metformin in the next several years, as there's a large trial of using metformin in older adults with either cognitive impairment or gait speed impairment in older adults without HIV. So far we have pretty limited data on physical function effects in individuals with HIV. And then a very interesting study that came out just this last year. It's a small study, so certainly to be interpreted with quite a bit of caution. But this was a study looking at the effect of a senolytic, kind of targeting aging itself, an anti-aging drug, to reverse frailty and physical function kind of from a much more broad aging perspective. So this study looked at dasatinib plus quercetin. It was not placebo-controlled, so there was no control group. There were only 14 participants that were included, and they were all HIV uninfected but had idiopathic pulmonary fibrosis. It was an older group with a mean age of 71. And interestingly, the main focus of the study was actually on decreasing senolytic cells and decreasing inflammation. And the drug had no effect on senolytic cells or inflammation, but they fortunately included physical function as a secondary outcome and saw marked improvements in many of these physical function markers that we've talked about, such as 6-minute walk distance, 4-meter gait speed, time chair stance, and short physical performance battery. They did not see any improvement in grip strength or the frailty index. But I think this is some promising data of maybe some of this anti-aging effect that the more we can target aging, potentially could have some benefit on some of these physical function markers. So in summary, physical function or functional limitations and frailty can provide a window into patient vulnerability. They can guide clinical decision-making, protect people from harm, and avoid strategies that are not likely to benefit our patients. And they could serve as a clinically relevant endpoint for some clinical trials. Interventions should ideally focus on early impairments that occur in midlife, well before an individual becomes frail or experiences disability. Some promising pharmaceutical options, but certainly need more research on these in terms of the safety, long-term efficacy. Overall, physical activity is safe and effective in improving physical function, and physical activity counseling should really be a routine component of our HIV visits starting much earlier in midlife to increase both the lifespan and the health span of our patients. So with that, let's go back to those post-test questions to see if we covered all of these points well. So which option correctly reflects a consideration for choosing the 400-meter walk or the frailty phenotype in the clinical or research setting? So one, the 400-meter walk can be collected retrospectively. The frailty phenotype could be less useful because of a high proportion of older adults identified as frail. The 400-meter walk can be easily completed in the exam room. The frailty phenotype requires no equipment beyond what was available in the clinics, or it can be, a 400-meter walk can detect more subtle differences in higher functioning individuals. Great, so it looks like the majority answered correctly, which is that the 400-meter walk can detect more subtle differences in higher functioning individuals. Just as a reminder, the frailty phenotype required that dynamometer, which probably isn't available in most HIV clinics, although it may be in some. The 400-meter walk is a longer test, a quarter of a mile, so it would be pretty difficult to do it in the exam room, although it could certainly be done in a long hallway in the back of a clinic. The frailty phenotype is the high proportions really just seen in some much higher risk patient populations without antiretroviral therapy or really low CD4 counts. Most of the frailty prevalence in older populations tends to be about 6 to 10%. And then the 400-meter walk, unfortunately, can't be collected retrospectively because it requires walking a quarter mile. And the next question. What is the most effective intervention to prevent frailty and improve early physical function impairment among adults aging with HIV? And on this, almost 100% answered that this would be exercise, so I seem to have impacted that point well. So yes, exercise is one of the most effective mechanisms, potentially some emerging data on metformin, but I don't think it's prime time to recommend that yet. And so with that, I would like to thank my funding sources listed here from the National Institute of Aging, the study participants who participated in all of our studies, and my mentors and collaborators who are listed here. So thank you so much for your time. Okay, so I think we can move into some of the questions from the chat. And we have a question of, does peripheral neuropathy fit into the assessments of frailty? Most of the assessments for frailty don't include a measure of peripheral neuropathy, although we've seen very strong relationship with peripheral neuropathy and frailty, particularly in those that fall. There seems to be a strong association between peripheral neuropathy and the combination with frailty on fall risk. So it's not one of the standard components of the frailty phenotype. It is included as part of that frailty index in the initial frailty index that was developed by Ken Rockwood. Differences in the procedure and clinical research utility of a 4-meter walking track versus a 400-meter walking test versus a 6-minute walk test. And this is a good question. There's some thoughts about the difference between, I think some of this depends on who you ask. The pulmonary clinics tend to check more of a 6-minute walk, kind of having participants walk over that standard 6-minute time to see if their oxygen saturations are decreasing, and then you can measure the meters during that test. I think some of the folks in the physical function geriatric world, they prefer the 400-meter walk, in part because it gives a goal distance that someone needs to complete, and so they may push themselves a little bit farther to be able to complete that distance in a faster period of time. So it may provide a little bit more of a goal impetus to walk faster. We set up the 400-meter walk in our clinic in a 25-meter distance, and then someone walks 8 laps on that course. And so we can have a hallway that's fairly unobstructed and not a lot of people coming out. The 4-meter walk is really short, so that's like the distance across an exam room. We just mark those out in tape in our clinic or in our research center and can have a standard course that gets used for a lot of different studies. Data regarding gender-based aspects of frailty, yes, women in general tend to appear to be frailer than men in some studies. Women also tend to live longer, and so some of that may be a little bit of an age effect, but I think even in some, we did not see an effect in the HALO cohort in a lot of our markers, but we did see that women, I think, tended to have a little bit slower walking speed. So we do tend to see that women meet some of those criteria. The grip strength cutoffs are often gender-based or sex-based, and so those are going to account for expected differences between men and women to help pick up some of the differences there. Is frailty related to CD4 count? Absolutely, and as I showed on some of those slides, particularly related to the prevalence of frailty. I think that those with the CD4 count that are much lower tend to have a much higher prevalence of frailty, particularly even those that tend to have a lower CD4 nadir, we may see a little bit more there. So certainly we do see a risk with low CD4 count, even more reason to start antiretroviral therapy earlier and stay on therapy. It could definitely have a preventive effect on developing frailty. And then any benefit of growth hormone? Very interesting question. So most of the growth hormone studies in the HIV population have really focused on lipodystrophy and some of the body fat issues. We did conduct a study using tesamorelin, the insulin-like growth factor hormone, to look at the effect of tesamorelin on muscle fat as a measure kind of muscle quality. And we saw that tesamorelin decreased muscle fat. Unfortunately, we used just CAT scans that have been obtained, that were used and collected in some of the initial studies, and so we weren't able to go back and retrospectively add on those physical function assessments. There are some newer studies with tesamorelin and liver fat, and so it'd be really interesting to add on some measures of physical function in those groups. I haven't seen a lot on growth hormone more recently in the HIV population. There is some data in the uninfected population, and it tends to be associated actually with some more side effects, a little bit less on improvements in function. And then is there a benefit of amino acids for sarcopenia? I don't know of the data for that for sure. Certainly just improving nutrition and maintaining a high level of nutrition can be a benefit. And I think there was a question in the pre-chat, or the pre-evaluation regarding nutrition, and I'm certainly not a nutritionist, but I think that some of those nutrition factors, kind of maintaining a good diet, healthy diet with lots of vegetables, fruits, lean proteins can have a certain benefit in terms of helping to maintain lean muscle mass with aging. And a little bit back with that slide on the combination of diet and exercise, I think in people that are overweight, that are losing weight, it's also really important to try to preserve muscle mass and to make sure that the weight loss isn't a loss completely of muscle mass. So exercise becomes even more important in trying to preserve muscle mass with aging, particularly if there is an effort to lose weight and diet. Considerations for hospice care for people with HIV. I think that frailty may serve as a marker of someone who, after all interventions have kind of been stressed, that may be a patient that is high risk for poor outcomes and might be a discussion point for that. Obviously, hospice is a very personal decision and kind of deciding what's desired at the end of life, but it certainly might be a way to identify patients that are more eligible for hospice or more appropriate referrals for hospice care. Studies documenting the impact of physical function in racialized peoples. Certainly we have seen a stronger effect of Black race on frailty. Frailty seems to be more common in individuals that are Black, as well as a little bit of an effect on Hispanic population and some of the HIV cohorts within the AIDS clinical trials group. So definitely see some factors there, even after accounting for some of the socioeconomic differences. Let's see. Our measures in physical function and frailty, can they be applied to chronically ill youth? And that's a really interesting point. I haven't seen anything, I haven't specifically looked, but I don't think I've seen anything in the HIV population. There is an interest in developing better markers for physical function and frailty in some of the individuals who have undergone a transplant or a bone marrow transplant who have a very accelerated aging type process, even though they're quite young. Some of the difficulties with that are the ability of the children. So in infants, obviously they're not able to walk yet, and so you can't assess a gait speed. Their strength is quite weak, especially if they've been kind of bedridden. And so there's a lot of complications that go into the age of the child and kind of where they should be at appropriately. But there are definitely some efforts to develop those measures, particularly across the age spectrum in children. How do social isolation, PTSD, and depression exacerbate and accelerate physical function and decline? I think these are extremely important. There's some ideas of a social frailty, and that all of these concepts that make someone frail, or all of these social aspects such as isolation and loneliness and some mental health disorders can make people socially frail, and that social frailty may be just as important as physical frailty and certainly overlap. And we've seen that we haven't specifically looked at social isolation in some of our studies, but we have seen that other social frailty markers are strongly associated with physical frailty, and I think that's an extremely important measure. Do studies of frailty and HIV adequately control for confounders? I think many of the studies do, particularly those that have a well-matched HIV uninfected control group, such as that in the Veterans Aging Cohort Study, Multi-Center AIDS Cohort Study, the AIDS HIV Study out of Amsterdam, or the Women's Interagency, have this well-matched HIV uninfected control group with pretty similar risk factors for acquisition and similar social factors, and then also go on to adjust for differences between the groups. I think even more important than if frailty is more common in HIV after we've accounted for these factors is what factors drive frailty in HIV, and can we intervene upon those factors to help prevent and slow frailty. So we do certainly seem to think that it occurs more frequently after we've accounted for those, but I think really focusing our efforts more on what factors are associated with frailty or physical function impairments so that we can best intervene. How robust are the frailty findings? I mean, I think if that question's asking about are people robust or if the statistical methods are robust, I mean, I think we see certainly some spread of, we see frailty. I think certainly some cohorts are quite small. Some cohorts are quite large, and therefore I think are probably more robust in terms of some of the findings and the associations. In some of these cohorts that only include 50 patients or a fairly small group, it's hard to adjust for a lot of these additional factors and maintain statistical significance and kind of validity, and so those might be a little bit more difficult to tease out some of the factors. But I think altogether we certainly have a good literature on HIV and frailty. Reversing frailty, is it possible with HIV? Hopefully I answered that question. I think absolutely it's possible to at least reverse some of it. I think exercise and rehabilitation are extremely important measures and can be implemented early to help reverse some of those changes. The association with frailty and depressive symptoms, certainly a very strong risk for that, particularly with that overlap of those few components of the frailty phenotype that clearly could overlap with depression. So we see a very strong risk factor for a very strong role of depression in frailty. And some of that can actually be quite difficult to tease out whether frailty is more a measure of depression. In that case, I think that some of the more objective measures of physical function, such as the 400-meter walk, grip strength, those can come out to really assess how much of the physical function is physical and is objectively abnormal versus how much of it is influenced by fatigue and untreated depression or severe depressive symptoms. And then a question on how do we know if it's HIV-related versus natural aging. Again, I think there probably is an element of both. A lot of this is going to occur outside of HIV just because of comorbidities, outside exposures, inflammation, additional factors that happen. I think the key here is to identify the factors that are contributing to frailty or to physical function impairment in an individual patient so that we can intervene and try to prevent it. Whether or not it's just HIV or not, it's I think less relevant to the intervention in terms of how we might treat it. And then are there specific antiretrovirals or antiretroviral classes that can impact frailty? Absolutely, and this specific question asked about should we make an effort to try to switch older patients off of AZT if they're still on it. I think AZT, DDI, D4T, some of these older NRTIs are the most problematic. These agents have been shown to have significant impact on peripheral neuropathy, which another question asked about the link between peripheral neuropathy and frailty. So I think AZT in particular can have a lot of toxicity on muscle. So I think those older agents in particular seem to have the biggest risk factor for physical function and frailty. And we should make an effort, especially as newer therapies are available, to really try to get people off of those older NRTIs. In terms of other sort of older therapy like abacavir and tenofovir, disoproxil fumarate, I don't think that we see the strong effect with those yet. There's not a lot of data on that. I mentioned that we did see a link between initial therapy with NNRTI and frailty in the HALO cohort, but we haven't seen necessarily a consistent effort of different antiretroviral therapy on frailty outside of those older NRTIs. And then for, let's see, do I routinely measure frailty onset with a grip strength measure or another device? As I mentioned, I think it kind of depends on what the purpose is. And if you're in clinic and want something that you can follow easily over time to see if people do have a change, if you don't have a grip strength or it's a dynamometer or it's difficult to move it from room to room or to have it sterilized in time for seeing patients with COVID, then I think the time to rise from a chair can be a super simple test that's done in 10 seconds or 15 seconds and can give a lot of information without having to have this extra device. And so I think that can be a great measure of lower extremity strength. If you're putting your own patients back in a room, just watching them walk to the room can give you a lot of information about their ability to walk, not necessarily the time, gait, speed, but you can gather a lot of information in terms of just watching a patient walk. A 4-meter walking course can be quite easy too, particularly if you had a standard where you measured someone's walk to the lab or out the door as you finish seeing them at the end of their visit and can record it and keep track of it over time. Do we still recommend checking vitamin D in all patients with HIV? Has it shown efficacy in prevention? I haven't seen as much on this lately. I think there is a lot more interest in the role of vitamin D on bone and on frailty when we saw such low bone density and the combination of tenofovir, disoproxil fumarate, and efavirenz, especially that those two drugs in combination seem to cause the lowest bone density and low levels of vitamin D. And so I think as we've transitioned more and more people off of that combination regimen and bone density isn't quite as low with the transition off of TDF and onto tenofovir alafenamide, I haven't seen as much of a push for vitamin D measurement and replacement. there certainly could be some improvement in muscle fatigue and muscle quality with vitamin D, but that's also weighing some newer evidence of potential risk for cardiovascular calcification. So I think, don't think there's a clear answer. I'll go back to, again, recommend that additional medications usually are less desirable, particularly in the older patients with polypharmacy, and the more that we can push exercise, I think, is even more important. And then just maybe one or two more questions. We're coming up to the end of that half an hour, but let's see. I think depressive symptoms we talked about, and then could I recommend any supplemental nutrition for individuals? And I think, again, this comes back to what is the source of the frailty, and if it's really that there's a loss of protein, that there's a severe loss of muscle mass that's not improving with strength-based exercise, or someone has a really hard time maintaining nutrition, and then meeting this with a nutritionist and getting additional information about trying to maximize nutrition would be important. But in general, I think trying to first improve muscle mass with lean protein, a healthy diet, and exercise is probably one of the most important things and the lowest cost. I think I'll end with this last question. Will frailty continue to be an issue for patients diagnosed since the advent of newer antiretroviral therapies? And I think frailty will continue to become an issue only because we see frailty with aging. And I think outside of HIV, many people are frail. Our goal with our patients with HIV is to try to minimize any added frailty that we see and try to keep people as healthy as we can with aging. As people get older and they experience additional comorbidities with or without HIV, some individuals will become frail. So just doing what we can to preserve maximum level of function. So with that, I think we were almost at the half an hour, and so I'll turn it back over to the sponsors.
Evaluation and how to claim CME will be emailed by tomorrow, 5 p.m. Pacific time, and this will enable us enough time to review those that have pre-registered in advance and those that have attended today's webinar. These are the list of upcoming COVID-19 dialogues. For more information, please visit the IAS-USA website. And this Friday, we have a dialogue regarding the status of treatment and vaccine research regarding COVID-19, presented by Drs. Sag and Screw. We have a virtual CME update this coming Thursday, and although this is directed towards physicians in the Midwest,